Welcome, everyone. Thank you for joining us for today's webinar hosted by the M.Dot Center. I'm delighted to introduce today's speaker, Adrian Aguilera, an associate professor in the School of Social Welfare at UC Berkeley. Professor Aguilera was a graduate of the first mHealth Training Institute that took place in 2011. Since that time, he has gone on to develop a very rigorous research program, developing and testing technology-based interventions to address health disparities in low-income and vulnerable populations, with an emphasis on Latinx populations. Today, we have invited him to share his insights about ensuring equity and inclusion in the development of these digital behavioral interventions for vulnerable populations. Just a little housekeeping before we get started. A recorded version of this webinar will be available on the MD2K's mHealth Hub. Please make sure you're on mute. If you have any questions during the presentation, please raise your hand, same symbol in your Zoom window, and we will unmute you. We'll also have some time for questions at the end. Adrian, over to you.
Great. Thank you so much, Vivek. It's great to be here with everybody. So as mentioned, I'm going to tell you a little bit about my work, but I'm going to start by framing the conversation to look at broader issues of mHealth, digital health, and with a focus on equity in particular. So I like to start often the conversations with putting things in perspective. And I don't know if any of you have seen or are aware of the digital health hype cycle. So this one's from 2017. And the idea being that there are technology triggers, right? Here's a list of a bunch from 2017. And then usually what follows is what's called the peak of exaggerated expectations, right? So we might think of, if this was done today in 2022, I don't think the latest one's out, Chat GPT and language models might be here. And then what often follows is a trough of disillusionment, right? These high expectations were not met. But what follows is the path of enlightenment and plateau of productivity. So this is an example of 2017. This was from 2018. One thing that's important to notice is many of these triggers, I didn't recognize and aren't even around today. Some are not, right? Or some have been forgotten, or maybe folks are still working to figure out the applications. I think it's helpful to look at this in order to put things in perspective, because I think a lot of times when we look at technology triggers, we get often overly excited, right? Expectations are too high. So I think it's important as we're engaging in applying technologies to think about not only what is their possible benefit, but also what are the challenges to using these technologies in possible unintended side effects as we engage in the early stages of things. I think we're seeing that a lot right now with these language models, in terms of there's been a lot of press about kind of how far they go in terms of providing misinformation or just frankly weird responses, right? And I think about that in relation to mental health in particular. All right. And then I wanted to just provide the perspective of where a lot of apps and mobile health in particular has been applied. This is a few years old, but I would imagine that the data is relatively similar. I might even venture to guess that we might have even more mental health and behavioral health apps, particularly since COVID. But as you can see, that over a quarter of apps, so the plurality of apps tend to go towards mental health behavioral disorders, others targeting diabetes, heart, et cetera. So as you all know, mHealth is quite applicable to behavioral issues, right? And there is probably no more behavioral issues than mental health, which is by definition related specifically to behavior, and for which we don't have great biological tests, for example, for these things. Here's a little bit of an overview of the mental health tech landscape. So there's some names you might recognize here. And I think some of these categories are helpful in thinking about how we're applying these technologies. So in one category, we have maybe what we might call computerized CBT. And some of these are in the digital therapeutic space. So they're being used as prescriptions. There's telepsychiatry, so just changing the way that we're delivering standard interventions. Provider tools. There's even some hardware that doesn't get a lot of press, but measuring kind of EEG, brainwaves, biofeedback, virtual reality, things like that. And then there's the applied AI, which is probably growing more than any at the moment. Another thing that's important to put in perspective, particularly as I'm presenting on some data in a bit, is this taxonomy of interventions that was developed by Ricardo Munoz, which just thinks about how we employ technology relative to our traditional intervention. So if we're thinking about psychotherapy, we might call that a type 1 intervention, so your standard face-to-face intervention. Type 2 would be that standard face-to-face therapy, but you add on a technology adjunct. So you may be reducing the provider burden a bit, but not that much, because that's still the basis of it. There are self-help interventions that are guided so that the technology is doing most of the work, but then there's a coach. And we're kind of venturing into that right now. And then finally, there are totally automated interventions where there's no or minimal human interaction, right? People are using the technology on their own. Next, another concept that's important related to that, right? Why we talk about combining human support is this issue of supportive accountability. And this is particularly important in mental health because we often talk about the relationship between a provider and a patient as being a tool to bring about change. And we've seen that. So David Moore and colleagues, some years back developed this supportive accountability model, really highlighting how human support can bring bond, accountability, and legitimacy, and provides motivation to help people engage in these interventions. Because we know that particularly with mental health, the apps are efficacious. Let's say a depression app is efficacious if somebody goes through the entire app for 8, 12 weeks, whatever the standard protocol is, but very few people do it on the whole. So if we go through that model, we'd be looking at maybe 15 to 20% of people would complete an entire intervention. The efficiency model is kind of an evolution of the supportive accountability model, really in integrating usability factors, so kind of UX ideas, and also thinking about what the interaction looks like. So thinking about the implementation of supporter models. So supporter can help engage the user and provide them knowledge. It can assess fit between the technology-based intervention and the user, and then can help implement to ultimately improve clinical outcomes. In terms of finding apps, there's a couple of app guides available. One is Cyber Guide. So these are guides to help people wade through, not only users, but even providers, wade through the large number of applications that are out there and try to make sense of it. Mind App is another one developed by John Toros's group. Again, to help identify, because there are so many apps out there, as we've seen. All right, so now kind of zooming in just a little bit more is thinking about who are we designing digital health for? And I think this is the question that is always at the center of my mind when we're engaging in technology development, technology implementation. And I think oftentimes we don't think about this, and there's kind of a default mode that we go into. And oftentimes what's easiest is for the default mode to be somebody like us or somebody like people around us. And we can see through, examples of these advertisements that when we think about, one of the most popular kind of digital mobile tools, wearables, the Apple Watch, the folks that are the prototypical user are people who are trying to optimize performance, let's say, not necessarily trying just to get to some baseline level of health, which is what I would argue what we need to do to think about impacting broader public health versus just optimizing health for people who are generally already relatively healthy. We also need to think about language access. So most apps, most mobile health applications are available in English by and large, relative to other languages. There are some others, some other major languages, but even when we think about Spanish, which large numbers of people speak around the world, there are not as many apps. That number is growing, but relative to the need, it's not there. So an English speaker actually can go out and have lots of options for what to, let's say, work on when it comes to mental health and find apps, whereas speakers of other languages have very limited options. When we look at the private sector, we also notice that one of the reasons that I would argue, and others have argued, that we haven't seen the broader public health impact of digital health is that in the development, folks often use healthy volunteers. They're not working with high burden populations, and they're not assessing outcomes such as cost or access to care. And so this results in not really decreasing the disease burden that we would hope, right? That's kind of been the big promise of digital health. And we're not really moving the needle there, unfortunately. And again, I think it's part because of the focus on who the user is, who we're designing for, et cetera. In thinking about mental illness, substance abuse, this is a little overview of what mental illness rates are depending on insurance coverage. So we can see that Medicaid populations have the highest rates of substance abuse or mental illness relative to other groups. Yet I would argue that most of the developments of digital mobile health is not occurring in the Medicaid populations, even though that's where we might be able to have more of an impact. When we look at keeping an eye on broader issues related to disparities, so we do know that racial and ethnic minorities are less likely to receive mental health services. And when they do, they receive lower quality of care. Unfortunately, I think this is transferring over into the digital health space. Folks from diverse backgrounds, particularly socioeconomically, face challenges completing even core functions of apps. So there's a huge digital literacy issue that we need to attend to as well. And lastly, I think the main reason that it's important to focus on these issues is that if we don't, we might further entrench disparities rather than overcome them. And that's my biggest concern. There is potential. So Latinx patients tend to be more smartphone dependent. So they're using these devices already, so we can reach them there. Folks have interest in using apps. Again, we need to think about the design. And we also need to think about who is participating in the development of these apps. What kind of patient populations are we working with? So one study found that very low rates of African-American men participating in these interventions. So if we're not we understand that user testing, user-centered design is so important, but if the users are not reflective of where the need is, then the impact is going to be limited as well. So here's an overview of technology adoption from a couple of years ago. For this from 2019. I don't think the numbers have changed too much. And as we can see, smartphone rates are relatively similar across three major racial ethnic groups in the US. Where we see some differences are in home broadband or desktop laptop computer use. So even though most interventions are, let's say, on a smartphone, broadband access may not be as readily available. And that is really important if we're having data-intensive interventions. So again, thinking about how we design and who we design for. National Academies of Sciences, Engineering, and Medicine had a digital health equity workshop a few years ago. And I think one of the key elements that they came out of the workshop with was thinking about that technology is really about people. And addressing disparities goes back to the foundation of placing the people first and not the technology first. And I think for many years, particularly in the infancies of digital mobile health, as we see by the digital health hype cycle, we often place the technology first. But as we've seen, as user-centered design has become part of the equation, we are moving more towards placing people first, and I would argue we still have some work to do that. Community engagement is essential in designing, evaluating, and adapting interventions. And this graphic's a little blurry, but I think we get the sense of how not only engaging community, but how we engage community. So in terms of how much influence and how much power communities have is also related to the impact that the ultimate interventions can have. So getting some information from the community provides some impact and some feedback, community involvement so that they're really engaged in the process, and we're not just asking them a few questions, but they're maybe involved in the development. And then community-driven approaches, which are really assessing their specific needs and what's important to them, what they see as impacting their lives. So I think we need to think about this continuum. We're oftentimes, I think, best case, we're in a community-informed model, but I think thinking about how we can move up the chain a bit. All right, so now with that intro, I'll now go into some of the work that I've been doing, focusing on depression. And so the first set of studies is related to a texting program that we developed for depression. And the basis for this was focusing on a problem. And so the problem has been attendance and engagement in sessions. So we have a big challenge in psychotherapy, where we know that the more people attend sessions, the better they do. But there's high levels of dropout and low levels of homework completion. So with cognitive behavioral therapy, we ask people to engage in homework, such as monitoring their mood, monitoring their thoughts, their activities, and practicing changing those things. Before we engage in any intervention, this is what a standard attendance looks like to these group sessions. And what we see is that the modal number of attendance is about 2. So people will attend a couple sessions and then drop out and never come back. Ideally, it would be around 16, which is the length of this particular intervention, this course of treatment. Attrition has been a problem broadly in mental health and psychotherapy, and it's particularly problematic in low resource settings and with ethnic and racial minority patients. And then we've also talked a little bit about how technology-based interventions suffer from their own attrition issues. So we're addressing kind of the challenges of attrition in both of those aspects. So with the mood text project, what we want to do is leverage text messaging. So what's been called the workhorse technology in mobile health to improve treatment quality and engagement. So we use text partially because of when we started. We started this project back in 2009. And this is what I was working on during the 2011 mHealth Summit. And it's widely accessible. There's high engagement rates. There's also, I think what we found is a sense of personal connection, because it's an app that people already use to communicate with others. So we bring that to the intervention. And that's something that we don't really get when we have somebody use an app that we've developed that people are not familiar with. And they don't see it as an app for personal connection, unless it's something like WhatsApp or something like that. So the model of this group was a 16-week treatment with 4 different modules. There's rolling admission, and the first round of data will be focused on Spanish speakers. And what we did is we compared participants using standard group cognitive behavioral therapy for depression to those receiving the group treatment, but with an automated text messaging adjunct program. And here's an overview of the patient population. I think some things there were no differences between the texting and the control group. And some of the things to point out, I think, are the average age was 52 years old. Most people had less than a high school education. So there are cultural differences that we definitely need to attend to. But I think one of the things we don't talk about as much are education differences and literacy issues. That being said, most people owned a smartphone, and most people used SMS prior to. For those that didn't, we had protocols in place where we did a brief kind of training of how to respond to a message, etc. So the way things were done previously were to complete a pen and paper form where you list the day of the week and then indicate your mood every day, and then maybe answer another question, such as how many healthy activities did you do on that day? And so what we did is we took this homework and converted it to a texting program. And part of that texting program includes a mood monitoring text messages, a theme-based text, which is related to, for example, how many healthy activities did you do each day? And then we also sent medication reminders to people who wanted them, and then group attendance reminders. But the bulk of the intervention is these mood monitoring texts and these theme-based text messages. So for example, this is a daily message people would get at a random time. What's your mood right now on a scale of 1 to 9? And we ask people to respond with a number and what they're doing or thinking. We provided feedback randomly 20% of the time using a variable ratio schedule, which we know provides the highest rates of response, akin to kind of a slot machine effect. The content that we replied with was roughly tailored around mood ratings. So higher mood ratings, middling mood, and low mood ratings. Things that were reinforcing the mood or provided some nudges to help people raise their mood a bit. These are theme-based text messages that were, again, focused on what we were talking about in session that week, that month, thoughts, activities, social interactions, for example. And these were sent in the evening, kind of as a wrap up to the day. Medication reminders, and then group reminders the day before. When we got the data, this is what it looks like. This is an example of a patient. So if we look at the pink line, this is their mood ratings throughout the week. And what we would do is then we focus in on, let's say, the 6 on the Tuesday, and then compare that to what's happening the next day. So 6, estoy en casa, I'm at home. The next day, Wednesday, 8, estoy con una amiga, I'm with a friend. So we can contrast those, the difference between being at home versus being with a friend. We can pull out what the thoughts were what thoughts were going on during that day. On the Thursday, disfrutando un día muy bonito. I'm enjoying a beautiful day, right? That's those kinds of thoughts are related to mood. And so we can continue to reinforce the relationship between thoughts and moods and behavior and mood through this process and help people engage in that process themselves. And what we found in comparing these groups is that texters attended over twice as many sessions compared to non-texters. So 6 sessions versus 2.5 sessions. And texters stayed in treatment over 4 times longer. So this is the most dramatic outcome. And I think this is pretty important because even though people may miss a session or so, particularly when you're depressed, motivation is challenging. And depression ebbs and flows. But getting these automated text messages provided a sense that the group was there for people when they were ready, because we constantly sent messages even after they weren't there. And so what we saw is people would come back even if they missed a few weeks, whereas if they're not getting that type of feedback, they're less likely to return to the group. So we know that the text messaging adjuncts can decrease treatment attrition and resulting in helping more people get better. We also wanted to look at the data to see what we could learn from the mood ratings on a daily basis. And in particular, we wanted to predict whether or not someone was going to show up to sessions, since engagement was such an area of focus. And we did find that prior day mood was predictive of session attendance, such that an increase in mood relative to their average resulted in 32% more likelihood of attending session. And why is that important? Because then we can identify critical points for microinterventions. We can inform tailoring when we can provide outreach based on the data that we're receiving. We also looked at average mood via text in the past week and how that was related to PHQ-9 symptom severity. So the PHQ-9 is the standard screening measure for depression that's used a lot in primary care. And there was a relationship with the PHQ-9 and average mood ratings in the past week. And that's, although it's a relatively simple analysis, just looking at the relationship, what it tells us is that we can use possibly simple mood ratings to assess symptoms and provide screening. Screening is happening quite a bit in primary care, but this can now happen possibly remotely rather than having to have people fill out a complete PHQ-9. We looked at clustering users. So we know that personalization is important. And so clustering the types of users is one way to start to get a handle on that. And we looked at folks who attended a lot of sessions and then folks who responded to a lot of text messages. And we see that there are about 4 clusters that came out. The high texters and high attenders, some of the factors that were related to that were that they preferred texting to begin with. So we kind of met them where they were in terms of their technology and their age. They were on the kind of younger side. They weren't the youngest group, but they were on the younger side. The other group who attended a lot of sessions but didn't respond as much was an older group. So they're maybe more motivated, but not as tech savvy. And both of the groups who attended more had lower baseline PHQ-9, so lower symptoms to begin with. So it's important to start to understand the groups in terms of who this might work for and then how to adjust the intervention as well. All right. So some of the feedback that we received from this intervention was And this was a bit earlier during the development of the intervention, was from English speakers. And a lot of the feedback is related to stopping and thinking about how I'm feeling, looking in the proverbial mirror. So self-reflection, which is really important and a base kind of intervention for mental health. In order to make any changes, you first have to be aware of how you're doing. And Spanish speakers mentioned that as well, but they tended to mention other things as well. As you can see by these quotes, some people said they felt cared for and supported. I realize that someone cares for me and I don't feel alone. People care about my health. So there are relational comments. And what's interesting about this is to think about the cultural differences in terms of how people experience these interventions. Even though it's the same text messages being sent out, albeit in a different language, they're interacting with the user and what the user brings to the table. And in this case, users are bringing a relational frame, and that's what they're seeking. So it's important to keep that in mind as we develop and implement these tools. In terms of suicidality, which is a question we often get, we do instruct patients that this is not direct communication, that it's an automated program. However, patients still feel a sense of connection. We have some keywords that trigger messages to clinicians and research administrators of the system to check if there's anything of risk in the system. We looked at, because digital health literacy is an important factor in the populations that we work with and in the implementation, we wanted to understand what are some of the factors related to digital health literacy and response rates. And we did find that education levels in particular are related to responding to messages, to how much content you get in the messages. And then knowledge of texting and whether or not you texted in the past was related to response rates. So again, thinking about meeting people where they are, and also building the capacity. So helping, this is text, this is relatively basic, but we need to engage in some sort of training to get people's skill level up to a certain point so that they can engage in the interventions as well. So from the Mood Text project, what we've learned is that patients who text attend more and stay longer. Prior day mood rating predicts attendance. Mood ratings via text can approximate PHQ-9. Patients generally like interacting with automated text, and digital literacy issues are real, but they're also addressable. When COVID started, we decided to leverage the text messaging platform into a broader reaching intervention. And so we wanted to send out messages to help aid people in healthy coping during COVID-19, particularly during the early days of social isolation. So we developed the Stay Well at Home program, which is a 60-day CBT texting program where people receive 2 messages a day. And these are examples of messages. Some were related to, let's say, getting sleep, and then we would ask them for their mood rating afterwards in order to start to learn which types of messages were most helpful. And what we found during this initial phase where we just provided the resource out to everybody, we didn't quite feel that we could randomize people into a control condition at this time because it was a sensitive period where we wanted to provide resources to folks. But what we did see is we saw a decrease in the PHQ 8, no suicidality in this version from 9.3 down to 7.5. So not a huge drop, but a significant drop. And I think that what's important about this is that even though we're not making huge impacts at scale, these small impacts can add up potentially. However, we still didn't have a sense of how this varied compared to control. And we also wanted to look at how reinforcement learners could help us personalize messages. So we wanted to then take the next step in the stay well intervention and look at the differences between a control group, which was only getting a mood rating message, and then some feedback message at different rates. Compare a uniform random group, which was getting a random message from a set of messages, and then compare the reinforcement learner group, which was which had a reinforcement learner applied at the individual level to start to learn which types of messages and which types of categories people were responding with higher mood ratings. And this data is relatively new, kind of hot off the presses. We're still working on it, but we're starting to get a sense of some of the differences. So in terms of pre-post, we recruited from two different types of samples. One was a health match, which is a registry that matches folks who are interested in studies to studies, and they tend to be more clinically symptomatic. So as we can see in the baseline, these folks had pretty high PHQ-9s of over 14. So 10 and above would be the moderate range. So these folks are definitely in the moderate depression range. At the end of the intervention, they went down to closer to 10, so almost down in the mild range. We also did some recruitment broadly via Facebook. And as you can see, these folks are not expressing as many symptoms, so they're more in the mild range and then go down as well. And we see the same in terms of anxiety scores. GAD-7 is the anxiety scores. So both decrease, and these are significant decreases. And this is for all folks in all conditions. When we looked at differences by condition, so comparing the control, random, and reinforcement learner, unfortunately, we haven't found any significant differences. And so we're in the process of exploring a bit why that might be. Although there's some indications that there might be some improvements, at least between control and random or reinforcement learner on anxiety, there don't seem to be others. And what we have to ask ourselves then is, does that mean that our intervention doesn't really work, or does it mean that our control is too good? The control intervention asks people to rate their mood ratings on a daily basis. And some of them got some basic feedback to that, whereas the random and reinforcement learners got additional messages. So they got more messages. But what we're seeing is more messages may not be that much better. So this is something we need to dig into. In terms of the reinforcement learner, one of the challenges is that we did use an individual-based model rather than a group-based model. And it's possible that this limited the ability of the model to start to personalize for individuals. We're also using self-report. So if people are not responding to the mood ratings, the learner is not able to take that information in. I pulled out some random feedback from folks just to get a little bit of a sense of what people said. And generally speaking, I tried to pull from people who said that the intervention was helpful, was kind of neutral, and people who didn't like it that much. And so generally speaking, people all talked about the awareness of their mood, and that being a central component to the intervention. So that means that even the people that are getting a control intervention, getting a regular daily mood rating question, that may be such a key ingredient that it's maybe not truly a control condition. One downside, as mentioned here, is although it was positive to be aware, one person did say that realizing that their mood is barely ever great was not very pleasant. One way to think about this ideally would be perhaps this could be a way to step people up to more intensive interventions. Most of the feedback that was suggestions for improvement. We're thinking about expanding the program and helping it be more personalized. So people wanted to pick the time of day that they got messages, even though the learner tried to incorporate some of that, it didn't really do a good job, at least at first glance. So we'll look into that further. So effects are relatively small, but they are scalable. So we're going to keep looking into this, and also trying to assess what factors are related to who's benefiting and who's getting the most out of the intervention. I'm going to quickly run through the Diamante intervention. I think it would be helpful for this group, and is another, it's kind of a more advanced way to think about using reinforcement learner interventions. We started this before the Stay Well intervention, but we were able to kind of get the Stay Well program up and running more quickly. So Diamante is a intervention focused on people with depression and diabetes, and looking at physical activity as a core mechanism of intervention. Addressing some key issues in mobile health interventions related to personalization, integration into care, and being developed with needy populations. So we know that physical activity is a core mechanism in diabetes and depression, among other health issues. And really focusing on designing for people from low-income backgrounds with low health literacy, and for ethnic minority backgrounds. So personalization is extremely important, and even most apps that target changes are not personalized. Doing things like cultural adaptation is extremely important, but even that doesn't account for individual differences. So reinforcement learning can help us move in that direction. So the goal of this project was to increase physical activity via passive sensing, applying a reinforcement learner to target specific motivators. This is a screenshot of the app, tracking steps, and then people would get messages giving them feedback on their steps from the previous day, and then some sort of tip to increase activity. This is again, feedback message, and then a motivational message. And we used the model that we used to base our categories is the COM-B model, the capability opportunity motivation model, developed by Susan Mickey and colleagues. And the reinforcement learning, some of you know, is a way that the software agent can take actions to maximize a reward, which in this case is physical activity. Here are some of the important terms. I'm going to run through them a little bit quickly to leave time for questions. I think some of you are aware of how these models function. And so the action variables that we used were feedback messages. So no feedback, reaching a goal steps, or kind of a more or less feedback, and then a motivational messages. So these are related to benefits, self-efficacy, kind of more motivational things, and then opportunity messages. We also varied the time of day and had that be something that the learner personalized on as well. And then there are other contextual variables that are included in the model. So every morning, the algorithm is retrained on data of all participants. So this is a group-based model, which I think in hindsight, the Stay Well intervention would have likely benefited from being a group-based model versus an individualized model. And the reward, as I mentioned, is the steps that the model predicts to increase based on previous data. So this is a quick summary of training the 3 different algorithms, evaluating the reward, and then learning over time. So the implications are to assess the impact of algorithmic personalization, testing in a resource-constrained environment, and hopefully the results being relevant more broadly. We just finished this intervention in December, so we're processing the data and hope to have it available soon. We'll be presenting this at the Society for Behavioral Medicine in April, so we'll have kind of our first look then. So that is all. Let me run through the end. Whoops. All right. I just want to make sure to thank all the folks that have been involved in the project. This is really team science at its best. And thank you all for being here.
Thank you. That was a great talk. And we'll just go ahead and open it up for questions. Feel free to raise your hand, or to just, if no one else is speaking, you can just go ahead and ask your question. It always takes a minute. Do we have any questions?
I have a question about, so first off, thank you so much for the really informative talk. It was great to hear about all the amazing work you're doing and bringing equity back into this space. I guess one question I had is, a lot of the work in terms of using recommendation learning systems and other tools seems like a really similar approach to what we would take with the healthy volunteer populations that, like the examples you gave. And I guess like it's been interesting to find this balance of like, that's a really modern technology that like might, so I guess how are you able to adapt modern technologies like reinforcement learnings and all these advanced systems while kind of maintaining that community driven aspect? Because one thing that's always been really confusing to me is it might not be what someone in that community might think of this would really help me, but professionals who work in that setting and technologists might kind of have a nascent idea that they think might apply. So striking that balance seems very complex. So I was wondering if you could say a little bit more about your perspective and approach to that problem.
That's a great question. And I think that, so we did, I didn't talk about it as much, but for the Diamante project, we really engaged in a process where, for design, where we started with some kind of theoretical context for engaging in behavior change, right? So that we started with some universe, and then we brought that to users, and so we conducted interviews and asked folks about their feedback. And so with that, we got to see what was kind of striking a note based on what we had, but also getting new information from them. So one example for that is in the COM-B model, there's capability, opportunity, motivation. And what really came out is people wanted kind of inspirational type messages, right? Things that just make you feel good. And so that's something, so the messages in the motivation category, we move them more into that inspirational type of category. And so I think the basic response to your question is that we can make recommendation systems, but we still have to know what the universe of recommendations is that's gonna connect with users. Right? You can make a recommendation system that's trying to recommend a bunch of things, but none of those things could be relevant to users, right? So we have to populate the system with things that are relevant to users' lives, that they like. And I do think that sometimes people can tell us what they like, and that may not be what they respond to, right? And that's okay as well, particularly in mental health. I think the challenge with mental health is that the things that you need to do often is to face things that are difficult to face, right? And by nature, by definition, we often don't want to do that. So and so we're always striking that balance. I mean, it's kind of akin to working out or, doing things that are difficult. We don't want to do it, but that's often what's best for us. And so kind of nudging folks in that direction, while kind of attending to what are the best ways maybe that has worked for you in the past. That's kind of one way to think about how to build the content of a recommender.
Thank you. That makes a lot of sense. Just a really brief follow-up question to that is, I really like the example you gave of like pushing the motivational messaging in a direction of inspirational based on what participants said. I was wondering if, like, I can absolutely see how the idea of respecting what they asked for can probably kind of drive that sense of equity of like people who are developing these technologies are listening to me. But have you considered evaluating whether or not including a general message bank versus an inspirational one actually makes a difference in their engagement? Like, even if it's, it feels good that they said that that's what they want, does it actually matter in the end, or is it just kind of a respect aspect? Does that make sense?
Absolutely. Absolutely. I think that one of the ways we'll be able to look at that is, particularly for the Amanta study, we're going to be able to look at afterwards which types of messages were most related to increase physical activity. So that'll be the proof will be in the pudding, in a sense, right? And I think the other thing is that when we think about recommender systems, I think we also have to think about, in order for them to learn what works, we also have to know what doesn't work. So a colleague, Elad Yamtov, kind of always mentions, and it sticks with me, that we have to give people things that they might not like, but that they don't hate enough to just leave the platform, because you want to get that range of what works and what doesn't work. That's how you can better learn.
Great. Do we have any other questions? Don't be shy.
I have a question. Thank you so much for this talk. So one thing that I was thinking about when you're presenting is like a question that comes up in my own work is this tension between individual level models and group level models, and maybe some sort of cluster based model in between. Yeah. But it seems like it's a hard decision to make. And I'm just wondering how you think about that and make those decisions in your work, and what sort of are the variables and constraints that go into it for you?
Yeah, that's a great question. I think that, I think that we're learning a lot about these types of models. And so I'll kind of chalk it up to learning. But I think on the one hand, I think individual-based models can help, possibly, in theory, when your user base is so diverse that you have to take into account the individuality of the users, right? Whereas group-based models are likely, at least from my perspective, to work most efficiently when a group is more homogeneous. Because it's possible, if they truly do have different motivations, then the group model could be working against itself in a sense. So I think a cluster might be another way to think about it. One of the things that we plan to do now that we have all this data is to run some simulations using individual models, using group-based models, maybe using clustered models, to think about which ones are going to work most efficiently. I do think that although there are benefits of individual models, it's likely that we're going to lean more towards group-based models just because of the efficiency that they're bringing us, right? So any of the benefits that an individual model could give us is going to be limited greatly by the amount of data it can get and how quickly it can get. So an individualized model is going to work if you're getting, loads of data, constantly that can adapt, but we're getting one data point a day. That's not really enough to train it.
Thanks. That's really helpful. And it's interesting to think about when you're talking about people aren't using these programs for that long. So you don't have that long to get that data. Thanks.
Yeah, because let's say we did 60 days for the texting program. Let's say people are responding about 60% of the time. That's about 40 data points. It's not that much. And even within that, the range of data is going to be limited, and people's mood is likely impacted by lots of things, not just the message, right? There's external factors that are going on, and it's hard to have a sense of all of that data as well.
Right. It looks like we might have time for one more. Anyone else? Okay. Well, oh, Anja, did you have something? I don't want to cut you off.
I was just wondering, well, first, thanks a lot for the talk. It was really inspiring. Since you were talking about external factors, I was wondering whether you're also taking into account like family situations or like surrounding environment of these people, because they want to undergo some kind of behavioral change. But if you're having some kind of discouraging environment, probably they're not going to make it because they do not feel motivated by the people surrounded by them. So I was wondering whether you're also taking into account such factors.
Yeah, that's a great question. I think there's always a balance of how much data we can get, relative to like most efficiently to not overburden participants. We have collected, particularly for the Diamante study, we do have more of that kind of data. I think another example is that we also included seeking support or getting, engaging in physical activity with others, for others, et cetera. And interestingly, some people would tell us that they don't have anybody in their lives, right? So that doesn't work for them. So that's kind of another level of thinking about personalization. So I think we need to think, we're not quite at the point where we have a clear sense of what those factors are, because there's external factors, but then there's also a lot of personality level factors, right? Some people, there's sense of openness, for example. Some people are pretty open. You'll give them anything and they're just flexible and they'll say, sure, that's great. And they'll look at more of the positive aspects of it. Other people are going to be, looking to kind of nitpick and not like something. And then there's kind of other people in the middle. So I often find that these things break down, whatever variable you look at, it kind of breaks down into thirds, roughly. So I think with what's going on around you, absolutely. The challenge is, what can you do about all of it? So I think you want to understand what's going on in the context. Ideally, recognize it. So call it out, I think, is important, so people can feel, seen and heard in their situation. And then one thing we don't know as much is how to address some of those, external factors that we know matter, because we're working so much at the individual level. So I think that's one of the big challenges going ahead.
Thank you.
Thank you.